Good afternoon, everyone. My dear friends, today I'm going to have this webinar on ovarian transplant, a new frontier, in which I'm going to take you on a journey, my journey of achieving this ovarian transplant. Hope all of you enjoy this journey along with me. And at the end of it, I'm going to share with you some very important historical anecdotes which are sure to amuse you. Now, before I begin today's webinar, I just want to make a statement that throughout this journey, a lot of people have helped me in achieving this goal. It is practically impossible to take individual name and acknowledge them. But in general, I would like to pledge my thanks to all those who have helped me in achieving this. The story actually began in This is St. GS Medical College, KM Hospital, Mumbai. This is my alma mater. And actually the story started in this very premises. Dr. Christian Bernard, who did world's first heart transplant, was invited to speak at St. GS Medical College, and the lecture was arranged in main lecture theatre. The theatre was jam-packed with more than 400 to 500 people, students and professors all included. After the initial fanfare, the lecture started and Dr. Christian Bernard asked for the slide. Now in those days, there were slide projectors which were there. Somehow, unfortunately, the slide projector conked. One after another, they asked for many slide projectors, but somehow they wouldn't function. At the end of it, exacerbated, Dr. Christian Bernard just got up and said, what India needs is a working slide projector and not a heart transplant. This was a very, very damaging statement, a very, very infuriating statement to a young mind, to a students like me. And that was something which triggered the spark. The lecture that did not happen as should have, but ignited a dream in me. The spark was in 72, thanks to Christian Bernard, but the dream goal was that I will work in the faculty of transplant and I will try and do something which no one has done. So this particular dream just remained the dream till I appeared in 1978 for my postgraduate MD examination. And that's the time the whole goal was set. Now, this is a memorable time for me because in this examination, I was given a case of Turner syndrome. And this Turner's girl, after examination, I presented my case and came to a diagnosis of a mosaic Turner syndrome. The examiner asked me the management of this. And after narrating the routine management, at the end of it, I said that this girl probably is lacking a functioning ovary. So I would like to give her a new ovary and do an ovarian transplant. The examiners were aghast to begin with, and they were quite upset also with this answer. They thought that as I have presented it so well, I must have seen this patient before. And they challenged me that on the last day, they will re-examine me. All 8 examiners together are going to grill me and see whether really I know my subject. The last day appeared and I came for the re-examination. There were all 8 examiners sitting on one side and poor me on the other side. 4 hours transpired in between this duel. At the end of it, they got tired and they said, boy, you seem to know your subject well. And very generously, they offered me everything which was permissible at that particular examination. They gave me a distinction. They created a special grade of G4+. They gave me all the gold medals, not only the gold medals for OBGYN, but there was in general gold medal for all the faculties together, the Prince of Wales gold medal. The certificate was printed in red, and this stands as a record in the university for more than, I think, 70 to 80 years. At the end of it, when they said that you seem to know your subject well, but we just want to tell you that you are living in a fool's dream. There is nothing like ovarian transplant, so be practical. Something very funny happened. Almost after 24 years, after my postgraduate exam, when I first recorded my success of ovarian transplant, one of the examiners, Dr. Fonseca from Sion Hospital, called me. He congratulated me, and his words were really etched on my mind that, boy, we were living in the fool's dream, not you. And this is how the goal was set for me to achieve the ovarian transplant. The transplant history began with achieving eternal youth with gonadal transplantation. However, other organ transplant developed rapidly. To achieve this was a very daunting task. I had many hurdles and stumbling blocks in my journey, but I continued. One of the first things I changed myself, in spite of being an honorary professor, I changed my philosophy and being a student, a rather student again. And that is the way I started my journey of the ovarian transplant. The story almost encompasses 20 years of hard work, which included animal experiments, cadaver dissections, immunological studies, renal transplant observership, learning vascular and microvascular journey, too many things, but believe me, it was an enjoyable journey. These are some of my friends, dear friends, which you can see here, in whom I started my experimentation. And I must pledge my gratitude to Johnson & Johnson, BMC Dog Center, in which they used to do the castration of dogs. And we would go there, get those castrated organs and re-implant them just to practice our microvascular techniques and vascular anastomosing technique. I am also must be thankful to ICMR, or Indian Council of Medical Research, or NIRRH, what it is called today, for the various experiments we conducted there, which was published. Thank you, my dear friends. The cadaver dissection was something which was a highly educating thing. The anatomy, what we learned, the physiology, what we learned, here in cadaveric dissection, I learned something which I had not learned throughout my life. And that was basically, we used to do the dissections in the female patients. Obviously, the pathologists and the regular staff were unhappy about it. The relatives were too keen to take away the body, but still we perceived and did this cadaveric dissection. And the important things which I learned there was all the pelvic organs have got vena comitante. That means they have got multitude of venules. The ovarian vein is not a single vein, but it is a mesh of venules which is surrounding the ovary. And the ovarian artery anatomy, which is very, very important, that although it begins from aorta and comes down to the ovary, that is all what we know, but it has many convolutions throughout its journey. And the reason for that, I'll explain a little later on. The most important thing which we understood was that if I need to do an transplant, there are no matching vasculature present in the pelvis for ovarian transplant. And last, the physiology of vascular pressure, which I learned. The next part of my observership, I wrote letters to majority of the transplant centers all over India, all over the world, because the renal transplant was the established practice then. However, literally 98 out of 100 letters were returned with saying that being a gynecologist, you will not be allowed to enter the renal transplant center. However, Dr. Bhalera from Hinduja Hospital was a very kind person, and he offered me the renal transplant observership at Hinduja Hospital, where I learned everything about the surgical technique of renal transplant, the selection of renal transplant, the post-transplant care of the patient, and how to go about it, And that basically formulated the ideas of my ovarian transplant. During this period, I wrote to many people, and one of the person, Professor Peter Morris, who happens to be a pioneer of renal transplant in UK, was quite impressed, and he offered me an observership at Oxford Center. And there, not only I was an observer in renal transplant, but he opened his doors to the cardiovascular thoracic surgery department, where I spent hours and hours together to see all the vascular surgeries which were performed there and get the ideas clear about anastomosis and how to take care of these vessels. Very surprisingly, after my first transplant, which happened in 2002, in less than 1 year, he invited me at Oxford Center to deliver an invited lecture. And that was the biggest honor, one of my first international talk, which I gave at Oxford, where I learnt my renal transplant. The journey was really long, it was arduous, and as usual, there was a lot of apathy from government officials. Actually speaking, in 1994-95, my first transplant case was completely ready to be operated. But unfortunately, that is the time when the renal transplant scam opened up and they just closed down all the discussion and wouldn't listen to anything about ovarian transplant. I had to wait till 2002 to start again my ovarian transplant. The path was uncharted, and to walk on this path was not very easy. The first and foremost, I had to register myself as a gynec transplant surgeon. And I'm very proud to say that this happens to be the world's first such registration of gynec transplant surgeon. As per the rules, I had to develop a center which was dedicated separately for ovarian transplant, and I did so again in 2002. These are some of the certificates of government recognition which came fortunately in 2002. And finally, on 29th March 2002, I performed the world's first successful ovarian transplant. The beauty of this transplant was it was with vascular anastomosis. It was orthotopic, meaning the ovary was placed where it belongs, and it was a live transplant, which is homotransplant. This is my first case. You can see here the picture of this girl with Turner syndrome, a short stunted girl. And the next is her sister, who happened to be her donor in the later part. Now this girl, you can see the picture, which is 3 years post-transplant, and you can see the recipient now has grown not only taller, fuller, full of all the feminine characteristics, menstruating and ovulating. One of the best things which I learned in this experiment was giving synthetic hormones do produce the changes in these girls of Turner syndrome. However, the biggest difference was the psychological change which I observed in this ovarian transplant. This girl prior was like a tomboy and would not mind hesitate examination anytime. With a drop of a hat, she would undress herself and get examined. However, post-transplant, her attitude completely changed and became a typical feminine attitude. And that is what surprised me the most. So what probably the natural hormones have are not there in the synthetic hormone. In the month of May, on 6th May, the government of Maharashtra took the press conference and declared the success of the world's first ovarian transplant. Actually, on the next day itself, BBC was the first one to contact me, and they not only interviewed me on BBC Live London, but BBC Asia, both Hindi and English channel. Later on, I was felicitated by Municipal Corporation of Mumbai, who had a civic felicitation for me with a gold medal. And obviously the Gynec Society, MOGS, also felicitated me with the silver plaque on the same year. These are the various publications, international publications of ovarian transplant. In 2007, I was invited in University of Georgia Medical College, where I gave a lecture on my ovarian transplant, A New Frontier. The very same year, copying my technique, an American professor did his transplant and published it as the first case in the world of doing whole ovarian transplant. It was a very painful news. We had to fight a long, arduous fight, and finally we won in this, and they had to apologize, and they published. In fact, Dr. Pravin Mhatre of Mumbai, India, published a scientific report of the whole ovarian transplant he performed 5 years before his case, that is 2002. And as an Indian, I feel very, very happy. So what makes this ovarian transplant different? It is basically the pelvic vascular anatomy, what is to be understood. Now, if you can see here, this is the pelvic vasculature. And if you see very carefully, this is the ovarian artery, which is coming here. And then you can see the cut ovarian artery. And this ovarian artery has got no other matching vessel at all. But if you see this inferior epigastric artery, which is a branch of the external iliac artery, you can see that's the matching vessel. And this was one of the steps which gave or opened the door for a successful ovarian transplant, which was vascular in nature. Now this ovarian vasculature, as I explained, it originates from the aorta. It has convolutions at 3 levels. The diameter is 2 millimeters. So if you have to anastomose them, you have to use an operating microscope. It is enmeshed in the venous plexus. And as there is no matching artery nearby, it was the greatest chances of failure were there. To circumvent this, I'll just go through this, some of the physiological and anatomical structure of the ovarian artery. And here you can see, although the ovarian artery comes from aorta and supplies to the ovary, it is not a single artery that goes into the ovary. There is a combined circulation which comes from the uterine artery as well as the oviduct or the fallopian tube. And this is the crucial part of success or failure of the ovarian transplant. Now, in this picture, you can see this is a vasculogram, and you can see the ovarian artery, and you can see the convolutions which are present there. Now, these convolutions are at 3 levels. You can see that the upper coils, middle coils, and lower coils. And these convolutions are not only in the size they vary, but in the number of convolutions also vary in different parts. This is the venous plexus, and you can see how the veins are there in a conglomeration. So one of the most important things for any organ transplant is that it has to have a single large draining vein. The success of transplant not only depends on arterial blood supply, but the main factor is the venous drainage has to be adequate. Even if the arterial blood supply is compromised, it can develop with angiogenesis the new blood supply. But the venous drainage cannot be developed on its own, and therefore we need to have a single large draining vein. We'll come to this part a little later. Now the reason why the ovarian artery has got many convolutions is the ovary is a low metabolic organ. And as it has got a low metabolism, but the blood supply comes on a priority basis from the aorta, like to the kidney, to the liver, or to the lungs, or any other major organ. It is not required there. And this requires to be reduced, the pressure has to be dropped down. And to drop this pressure, and bring the vascular pressure adequate for low metabolic ovary. The convolutions are present there, and it is enmeshed with the vascular, venous plexus. Reason is the same, to reduce the blood flow and reduce the vascular pressure. And this makes the transplant more difficult. Now you can see in this picture the ovarian artery and the different arteries which I tried to depict, and rather compare them in a simpler way to the solar system. Now if you see the earth is like a uterine artery. If you see the Mercury, that is the ovarian artery. And the end of the spectrum, you can see a Pluto. Now the Pluto and Mercury are of the same diameter. However, they're so far apart, to bring them together is a Herculean task. And that's exactly is depicted here. The inferior epigastric artery, although matching to the ovarian artery, I had to bring it down into the pelvis, and therefore it was very difficult for this surgical procedure. The venous anastomosis, again, as I said, the ovarian vein is not a single large vein near the ovary. So using it by a uterine vein, which is again a multitude of venules, inferior epigastric vein, which is again a vena comitante, is not possible. So finally, we devised a surgical technique where we got the ovarian vein at a very upper level, close to the abdominal cavity. And from there, select a large single vein and join it to a high drainage system of internal iliac vein. And that is the crux of our success of bringing the same diameter artery and a high drainage system of internal iliac vein. Very important thing to learn about the organ transplant is, although gonadal transplant started in the history, it died its own death. Well, other organ transplant developed very rapidly. The reason was, larger the vessel diameter, easier is the anastomosis. The venous drainage, I repeatedly keep on saying, very crucial for the organ viability. And the arterial blood supply may develop with neoangiogenesis. And that's the reason I say heart, kidney, or any other large organ transplant is relatively easy, while ovarian transplant and liver transplant, due to the vascular complexity, becomes a difficult proposition for us. Now, these are some of the pictures which I would like to just share with you. Now you can see this is a patient who has been operated 3 times for ovarian cancer, undergone an oophorectomy in the past. Now she has come for an ovarian transplant. Now if you see this incision, this is predominantly an inverted J-shaped incision right from midline going right above the anterior superior iliac spine. The reason is that we get a good access to the extraperitoneal space, and we can identify the external iliac vein, we can identify the inferior epigastric artery, and do the entire transplant extraperitoneally. The vascular anastomosis is done entirely extraperitoneally without touching the internal viscera at all. You can see the inferior epigastric here, which we are trying to dissect. We need to dissect it right up to its multiple insertion in the rectus abdominis muscle, which you can see in your left side picture. And this inferior epigastric, because of repeated surgery, you can see a lot of adhesions. However, in an virgin abdomen, you can see a very clear inferior epigastric artery. You can see those perforating vessels, and this artery again has got 2 veins which run along with it. So you have to clip this perforating branches, identify the inferior epigastric artery, and get a good segment of it which you can pass inside the peritoneal cavity to rather anastomose with the ovarian artery. Now this is the ovary which is going to be taken out, and here you can see very clearly the ovarian pedicle has been dissected off, but you can see very clearly the uterine component of this particular vascular structure and the tubo-ovarian component which is below here. And these are the venules and these are the vessels which need to be preserved, and you cannot cut them arbitrarily like what you do during oophorectomy. Now this vessel or vasculature is different in all the patients. This vasculature not only differs from patient to patient, but unlike other organs, it differs from right to left. And rest of the transplant organs, we can do a vasculogram and get the prior idea of how these vessels are there. However, in ovarian transplant, we do not have that luxury, and we are literally opening in Pandora's box, and we have to face whatever the structure is there at the time of transplant. Now you can see the pedicle which has been dissected off. And the hallmark of our success of surgery was, again, as I told you, a very long infundibulopelvic ligament, which needs to be dissected right up into the abdominal cavity. And that almost is 10 inches or 20 to 25 centimeters. Now, at that high level, you are likely to get a good single ovarian vein. So you can see in this picture how long the pedicle is. Now this ovary we are trying to dissect off, and now we have cut the medial end. After cutting the infundibulopelvic ligament, now this is transported into an isotonic solution, and each and every vessel needs to be catheterized and flushed with isotonic heparin solution to remove all the blood components which should not get clogged and the vasculature is suffering because of those clots. Here is a picture now of a cleaned out ovary with its pedicle, with its vascular system completely intact. And then we try and identify a single vessel which is large enough for us. Here you can see the ovarian vein which has been identified, a good single vein. But all the rest of the tributaries need to be clipped. Otherwise, there can be a leakage of blood and the whole transplant can fail. Now here you can see that ovary which is white, because right now it is devoid of any blood circulation. And this is the single large vein which we have taken up. In the lower right part, you can see the ovarian artery, which I'll show you a bit later. Now in the recipient, we do the extraperitoneal dissection. We identify the external iliac artery, external iliac vein, completely bare them or skeletonize them, so much so that these two vessels can literally be played around like a string. Fortunately, the external iliac vein does not have tributaries which are there in this segment, but surprisingly at times you may get one. Now here you can see the Deback's clamp are being applied to the external iliac vein and it is slit open. And on the right side, you can see the ovarian vein which is brought there. And now we are going to anastomose this ovarian vein end to side of external iliac vein. This is done with continuous suturing using 7-0 or 8-0 vascular sutures. After this has to be finished in less than 20 minutes because otherwise the lower limb blood flow has been cut off. Now this is the ovarian artery and this is the inferior epigastric artery which is turned into the space. And this anastomosis is done with interrupted 6 or 8 sutures which are 10-0 or 11-0. This being so fine that it needs to be done under the operating microscope. Having done that, now the anastomosis is complete. We check for the leakage and then we allow the blood to flow inside the ovary. And now you can see this ovary which is extraperitoneal. It has become pink because the vessels have started receiving the blood and the vein has started draining too. Entire vascular anastomosis is done extraperitoneally, and then we open the peritoneum and put this ovary right inside in the close proximity of the femoral end of the fallopian tube where it belongs. And that is how it becomes an orthotopic ovarian transplant. Now, there are various other factors which also affect the ovarian transplant, and that is the tubo-ovarian complex, which all of us know very well, but surprisingly, we really do not give much importance to it. Now, this vasculogram tells you exactly that the ovarian artery, when it is coming from the below, it not only directly supplies to the ovary and goes inside the ovary, but it branches outside, gives a communicating branch to the uterine side, and then it has got the tubo-ovarian complex, which is a part of it. So whenever you take this ovary out, you have to be extremely cautious that you do not try to damage this complex. And this fallopian tube needs to be removed very, very carefully. We wanted to keep the fallopian tube along with the ovary, but we realized that it will produce a larger immunological insult and the fallopian tube is not very well accepted. So then we decided maintaining the vasculature, but doing the fallopian tube removal. The next part is organ transplantability. It is very important to understand that any organ which is to be transplanted will have a scale of antigenicity. And this scale of antigenicity, the ovary does not belong to a very high level. In the transplantability scale, all of us know that because the paucity of nuclei, there is no nucleus in cornea, cartilage, and cardiac tissue, and therefore these tissues can be easily transplanted. However, the ovary has a master organ in terms of a cell potential, and therefore the acceptability theoretically should be more, but it is not so. The oxygen requirement for the growth and function of endocrine function in ovary are less, but for folliculogenesis, oxygen requirement is very high. Ability to ovary to be fragmented and transplanted to give its endocrine function is good, but this will not result in folliculogenesis. This is just an, you can see that ovary oxygen requirement is pretty low here. It's not very high. And please remember that if at all the blood supply to the ovary is cut and the nutrition is cut, what the first function goes off within few hours of death is the folliculogenesis. And therefore, cadaveric transplants are impossible in ovarian transplant. The next important problems are the ovarian transplant has to be live-related transplant. Now, as far as kidney, heart, lungs, other organs are concerned, you can be a donor at any age. It can be a small child, it can be an adult, it can be an old person. But for ovary, unfortunately, has got a reproductive potential only in the middle part of her life. And therefore, these rules were laid down that which ovaries, from whom can you take these ovaries. Fortunately or unfortunately, these rules were laid down by me because they were not there before. So the age of donor has to be less than 35 and more than 18. She should be married and she should have her children of her own, definitely telling that the progeny is normal. There is no cadaveric donation which is possible here. And last but not the least, cryopreservation of the ovary, which is not only tried by me, but world over, has been a failed project till now. Hopefully, when it comes to fruition, we may be able to do that later on. The question is, where do we get the donors? And most of the patients here are Turner syndrome. These girls come very young in their life, and then their mothers are also relatively young, so they can be their donors, or their sisters can also be donors. It has to be the age, the proven fertility, and related as per the law. But today, we know that any matching donor could be a potential candidate. Immunosuppression is an integral part of any transplant. And here in immunosuppression, we use methylprednisolone and cyclosporine. But probably we learned a very difficult thing in the later part, that cyclosporine, although helps to give us a great, good immunogenic problems, but however, it affects the progeny in the subsequent part. The newer concept, the newer drugs and immunological modulation is in pipeline. Just coming to the different part. Now this is entirely different. The blood transfusion is one of the first where the foreign cells are injected in your body. The first transfusion occurred from animal to human, and later on in 16th century, it occurred from human to human. Now, in the renal transplant, they did very good experiments. They wanted to produce chimerism, or ability of recipient to receive the donor's organ. So they injected small amount of blood repeatedly. And they found very surprisingly, if it was done 1, 2, 3, up to 7, they had a different chimeric response. But somehow, with 3 transfusions, they got the best chimeric response, which was not so in other transfusions. Why it is so? It's very difficult to explain. But I'm trying to work on this idea of doing prior 3 small blood transfusions to develop a chimerism so the acceptance can be good. Now there is a completely different aspect of ovarian transplant. The rule of vasculogenesis and angiogenesis. Now ovary is the only organ which has got vasculogenesis and angiogenesis as a normal physiological function. After every follicle ruptures, corpus luteum forms, and the ovarian surface regrows again, this vasculogenesis and angiogenesis always comes there. Now, what's the difference between vasculogenesis and angiogenesis? I'll just make it very simple for you. You want to build a building, erect a structure, that is vasculogenesis. Now you want to furnish your building and trim it up, prune it up, remodel it, that is angiogenesis. Now, for the folliculogenesis, the different factors which are there for vasculogenesis and angiogenesis are required throughout. And in the ovary, the biggest problem is vasculogenetic factors come from the recipient, while the angiogenetic factors come from the donor. And this is a biggest lesson we learned, why there is an immunological incompatibility because of normal changes in vasculogenesis and angiogenesis. This is something which really requires to be worked on. The donor matching is a big problem. It's not only the age and parity, but the blood group matching, both ABO and RH, histocompatibility antibodies major and minor, and we perform lymphocytic cross match twice to confirm that there is a possibility, no possibility of rejection. Lastly, in this journey of my ovarian transplant, I learned something, that we think we have done the transplant, but the great nature does a lot of things without us understanding that. And some of this, which I'll show you by my slides, adaptation by nature in vascular physiology. Now here you can see the transplanted ovary and a drainage vein, which is going into the extrailiac vein. Now, if you see in the upper part, because of this high drainage system, the initial Doppler study of this drainage vein was a very high consistent flow. Over the period of months, you realize now you see the lower part, and this drainage flow is like a very small metabolism having organ like an ovary. So who has done this change? Have I done it? The answer is no. It's been done by nature. Nature has adapted it. Similarly, the inferior epigastric artery, which is supplying this transplanted ovary, and this inferior epigastric artery in this proximal segment and distal segment shows a different pictures over the period of time. And you can see the distal segment, it's a very slow flow pattern, while in the proximal segment, it maintains its inferior epigastric characteristics. Folliculogenesis is the one which is very problematic in transplanted ovaries. We have folliculogenesis, which happened in our first case, right within the first 2 weeks of transplant. She developed a beautiful follicle. 2 months later on, she produced multiple follicles, which can be seen here. However, in the rest of the transplant, it takes anything between 3 months to 6 months to develop the folliculogenesis. And when the function deteriorates, there's a folliculogenic function is the first one to go, followed by the endocrine function. This is again a monofollicular development in the transplanted ovary. Now these 3 different techniques have been described, which have already been published. Vascular whole ovarian ectopic transplant, we had the longest survival of 9 years and the minimum survival was 6 months. While in avascular ovarian transplant, we had longest survival of 2 years and minimum survival was 6 months. 3 married patients had 3 pregnancies. Very unfortunately, probably due to cyclosporine, all of them aborted. Last but not the least, regulations. Are these regulations required? The answer is yes. Are they hindrance? The answer is yes. Just to cut short the story, if I have a case of ovarian transplant where donor and recipient are matched and ready, it takes anything between 1 year to 2 years before the patient comes for transplant. This stuff are the regulations. As in social obligation, we decided that this entire research will be done free. All this research, the financing was done by me, personal finance, but I must thank my entire team that all transplants were done free with nil surgeon charges. The entire team did not charge. And over and above that, the hospital also took a very minimal charges. Not here, but just to say one of my other research of vaginoplasty surgeries, where I've done more than hundreds of cases, 50% of the cases were done free of cost. Coming to the ovarian bank. In 2005, I was very happy and I wanted to start the cryopreservation banking of the ovarian tissue, basically for the young cancer survivor patients. I started it with ZIL, but here it required a lot of financial support. Unfortunately, I could not do so, and I didn't want the donations to come in, and therefore, finally 2 years down the line, I had to stop this cryopreservation project. Although we restarted this project with the Tata Hospital and wanted to start the ovarian bank, but unfortunately, it is still in the pipeline and has not seen the light of the day. Having given this long journey of my ovarian transplant, believe me, it was a very joyous experience to me, and I hope it was a joyous experience to you too. Now coming to the lighter vein, I'll be showing you some of the historical anecdotes which are important in the history of transplantation. One of the first example of organ transplant you can see is nothing but Lord Ganesh, where the head transplanted on the human body. All the mythological stories in all religions are replicated with many stories. Some of them I'm just going to narrate to you. King Yayati wanted his youth permanently, so he requested his son to give him his youth, and Pururava did so. This is the famous story of King Yayati and Pururava. In Christian mythological, you can see a person who lost his leg. A moose leg was transplanted, and this is a famous painting by Cosmos. and Damien. Saint Agatha, whose breasts were chopped off, she had the breast reimplantation done. And again, that's a beautiful picture, what you can see, the transplanted breast. People always have had ideas of an animal which would have capability and greatness of each characteristic. And all of them combined together would give us the best animal in the world. And that's exactly what is called as a chimera. Now, two cell line existing in a body is chimerism. And that is exactly one of our stumbling blocks in organ transplantability. 600 years before Christ, we can see the great Indian sage Shushruta. He was not only the father of plastic surgery, as well as he was the first one to perform the nose reimplantation or creation. Now, in those days, the nose was cut off because of some problems, and these people had to live an social outcast life. So he started doing this nose reconstruction technique. In late 1800 and early 1900, this treatise was published in the European Journal, and there was a frenzy of operations which was carried out there. And a very hilarious story comes out here. The noble people in the European countries, in those continents there, had a dueling fight or duels because of some uh, problems. Now, during these fights, the nose would get damaged. And then, where to get the nose from? So, in those days, they had slaves. They would hold a slave, cut off his nose, and then that nose was implanted on the master's side. Obviously, the poor slave would die because of bleeding, infection, eventually, maybe in a week or 2 weeks' time. And this nose on a master's face also would not live longer and would die. And then they termed it a very poetic term, saying that the nose dies because its owner died, and called it sympathetic nose. John Hunter, the father of modern surgery, did the first transplant, rather experiments, and boldened by that, he could grow a tooth on the cockerel's comb. A lot of tooth transplantation started happening in continents. They would forcibly remove the teeth and put them back into the different people or the honorable people. The tooth transplant would take because it really doesn't require much of vascular supply, and the root has got a beautiful cells which are every one of us knows that there are cells which are regenerating progenitor cells, and the tooth would take place. Funnily, you can see in 1792 an advertisement, a dentist has asked for several human front teeth and he would pay them, and this is the charges what would be paid for. Not only the human teeth, but they even dealt with hippopotamus and sea cow teeth and sea horse teeth. Very funny story about tooth transplantation. Now I'm going to show you a Chinese general. So this Chinese general himself was an extremely powerful person. He not only had a large flotilla which traveled from China up to the coast of East Africa, and he had won many wars. Unfortunately, he was a eunuch because he was castrated in the early age. And he carried his castrated testicles into, you can see the right side small pouch, and he tied it around his waist because the belief was gonads give them the power. Very funny story. The Fountain of Youth was performed by Emperor Caligula later part and even Pope Pius II. So what is this Fountain of Youth? This is a decoction which is created with animal blood along with the semen of young boys. And these people would drink it at a regular interval to maintain their eternal youth. All of you can recognize Charles Brown Secord, was the pioneer in the field of physiology, neurology, and endocrinology. All of you remember the Secord syndrome in neurology. Now, this particular gentleman, he did animal gonadal extract injections. And he not only announced this in an international journal, international seminar in Paris, and he said very proudly that everything I have done badly due to my advancing age, I am able to perform most admirably today because of these animal gonadal injections. And this is the elixir, the advertisement of his elixir of life. This was way back. Do we think that this only happened in the past history? And you will be surprised to know that this was even happening till 1960 in the best country in the world, which you can call of is USA. In San Quentin prison, thousands and thousands of inmates were castrated, their testes were impounded, extracted, and transplanted back. The many other ghastly surgeries were done there, but this is the gonadal extract surgery, which has really been infamous with the San Quentin prison. Dr. Lidston from Kansas, he declared that America is the first in the gland graft. And he not only said that he has operated upon himself to put the animal gonads into his body. And to the left, you can see the testicular grafting, a textbook which has been published, where from ape to man, a testicular grafting can be done or is being done. Now, this particular person, John Brinkley, was the biggest quack. And not only he did animal or goat gland transplant, he did something very funnily, is he even advertised that he has done the goat gland transplant and fathered a baby, and that's a first goat gland baby. He performed something like 16,000 testicular transplants or implants in those days. When there would be no human testicular glands available, they turn to monkeys. And this caricature tells you that the surgeons are after him to get his gland, but he's not very happy about it and a bit reluctant to do so. Many satirical comics did appear, and they were called as gland stealers. Well, as this funny part was going on, in the background, a lot of good work was also done. And the person, the father of renal transplant, was Alexis Carrel, which I will come a little later on. But however, all the great work was done, all transplant would fail because there was no knowledge of immunology. Till Medaber in 1950 came up with the idea of immunology. A story, so therefore from 1900 to 1950, practically nothing was happening. Now, Yo-Yo Voronoi, a Georgian surgeon from Russia, did the first cadaveric renal transplant in the thigh of a patient. And he successfully demonstrated that this kidney also produced urine and was functioning. But jealousy prevailed, and the other people just complained about him to the authorities. And the authorities asked him to repeat his procedure and gave him a kidney from a person who had died a week before. Naturally, this kidney failed and he was ridiculed very badly. Again, there was nothing happening. No kidneys were available. But suddenly, one of the surgeries which neurosurgeons started doing was hydrocephalic baby shunt procedures. And they wanted a beautiful tube from the same person. And nothing can be as good as ureter. They started doing unilateral nephrectomies, and the ureter was used as a transplanting tube. And these kidneys were thrown. As these kidneys were useless, Suddenly, a lot of people started doing the kidney transplant, and the first successful renal transplant happened in 1960, which you can see the picture on your left. Talking about Alexis Carrel, who's really a father of transplant surgery, he is credited a lot. Volume can be talked about his contributions, but in summarizing, I can just want to tell you, he was a great surgeon from France, but he was debarred for some problem and he had to run away from France. He came to US. As his surgical license was cancelled, he was put in pathology and physiology. But he worked so diligently that he won the Nobel Prize for Physiology. And he's truly father of modern surgery. Just a glimpse of some of his experiments. You can see the head transplant done into a white and a brown mouse. A leg transplant is done between a black and a white dog. Many such experiments he did, but the greatest contribution of him was the technique of vascular closure. And this he learned from Belgian women who were doing their needlework. Coming to a little different, interesting, which is called as the era of rejuvenation. Now, in this rejuvenation era, Paul Nihans first started his academy where he started doing injecting the animal extracts and giving the youth. Here you can see Pope Pius XII, one of his clients, and Paul Nihans together, that he would also go and get those injections. All of you can identify the statue. Charles Chaplin was a regular visitor to Paul Nihans, and he very famously stated that even at the age of 80, he can father a child because of these injections. This is Clinic Paul Nihans, which is in Switzerland, which is functioning even till today. Aren't you surprised that even this in modern day, such clinics are working? Now you can see to your right side bottom, a famous person with whom I started my talk. And will surprise, Dr. Christian Bernard gave up heart transplant and started this Clinic Rapare. And he started doing these injections of pregnant ewe, blood, semen, other organs, extracts, and giving youth forever. And the beautiful lady onto your screen is no one but Sophia Loren, who was his regular visitor. Coming to the last part, xenotransplants. As the transplants are progressing, we can see that we will have a paucity of organs. And therefore, can the organs come from animals? And everyone knows that a pig heart can be used today in the human beings. Can we use this xenotransplant in gonadal transplantation? Obviously, the answer comes as a very vehement no. We can't. But we are trying to use it in experiments where the architecture of the gonads is preserved, in which primordial follicles from the patient or human being can be injected and grown there, and as and when required, can be harvested out. Well, the science has no limits in thoughts and ideas and in practice. And this is a small summary which I wanted you to go through. I'm sure these are some of the anecdotes which you must have enjoyed. And at the end, I just want to thank Alembic Pharma for allowing me to conduct this seminar or webinar. I must appreciate the audience, and I hope in this postprandial period, you have not slept and probably enjoyed the talk. Before I conclude, I cannot say anything but a heartfelt thanks to all my team and all my patients to have faith in me and conducting this experiment and achieving the world's first ovarian transplant. Thank you very much.
Thank you, Dr.
Thank you so
Pravin.
much, sir.
Thank you for giving us the platform also to partner with you to give this kind of an interesting session. And the doctors, even in the forum, are also thanking you for such a beautiful and excellent session which you have given us. They are like, I can specifically keep on naming Dr. Rahul, Dr. Deepali, Dr. Vids. There are a lot of doctors who are saying thank you, sirs. Fabulous talk. Uh, just keeping on pouring. If I can just stop screen, you can also see those things, sir. It's like all the doctors were patiently listening to you, and we really thank you for the same. Now, sir, regarding any queries, I will request you, sir, to kindly provide them the email ID, or we will please post in your questions to our in this particular chat section. We will mail it to sir because seeing his sanctity of time, we are not keeping the Q&A here. So doctors are saying that okay, we will, ma'am, sir, if you can share us your email ID, that would be fine. Doctors who want to post their questions, because here now everybody is currently thanking you, thanking. I'll just stop share, sir. You can also view them.
Okay.
Yeah. Sir, if you guys see the chat section, you will find a huge number of doctors who are just thanking you. Dr. Pallavi, Dr. Indrani, Dr. Niyati, Dr. Rakhi. Now few
It
people
is
have
not
their
just
mobile
doctors, it's
phones.
everyone.
Yeah, everyone, absolutely everyone is thanking. So thank you so much, sir, for your valuable time. And we will definitely answer any queries which is there, and we will mail it to sir. And sir will definitely take his time to answer each one of your queries. So thank you so much, sir. Anything else, sir, you would like to add?
No, I'll just want to say thank you all for this patient hearing on a Monday afternoon, which is very difficult time to keep awake. Anyway, thanks a lot again to Alembic and to all.
Thank you so
Thank
much,
you.
sir.
Bye.